So last part of the of chapter 20, we were talking about the cardiovascular system, and we talked about the cardiac centers. And we have two types of centers that you have to know. One of them is called baroreceptor, and the other one is chemoreceptor. What's the chemistry that you're measuring? What do you mean by this? What chemistry? Oxygen, carbon dioxide, pH. Yes, if you remember that, that's good. If you don't remember, you need to put more time because I told you basics. I'm going to ask you about it, right? Basics. You have to remember it. What's the volume of the blood remaining at the end of contraction? Remaining in the ventricle at the end of the contraction. At the end of contraction. In systolic. Yes. And what's the amount of blood in the heart after complete relaxation? Not stroke volume. And diastolic. And what's the difference between those two? That's the stroke volume. And cardiac output equal what by what? By heart rate. Yes, heart rate. So if I give you a question and I give you heart rate and cardiac output, can you tell which cardiac output is right? Can you tell? If I give you like 60 milliliters, this is the stroke volume, and your heart rate is 70, and I give you four numbers, can you tell which one is right? Just multiply 60 by 70. That's it. Okay. For these centers, we have two types of centers. So chemoreceptors and baroreceptors, both of them are located in the same spot together beside each other. One of them is called the aortic, and this is at the arch, and the other one is called carotid, and this is at the bifurcation of the common carotid artery right here. Okay. And obviously, baro means what's baro? Pressure. Baroreceptors, pressure receptors. Receptors for what? For blood pressure, obviously, right? So it measures blood pressure. It monitor blood pressure. The other one monitoring the chemistry. And we talked about the three values of the chemistry that's going to change. And we talked about the location. And this is the feedback that goes to the brainstem to tell the brainstem what to do. So let me give you an example. My blood pressure is increasing. These receptors will pick it up. Which receptors? Baroreceptor will pick it up, right? It will pick it up. My pressure is increasing. Okay. And then these receptors will send the signal to medulla. To what? To do what? Acceleratory or inhibitory? Acceleratory. If the blood pressure is increasing and you send to the acceleratory will activate the sympathetic and will increase even more. Do you want your high blood pressure to go higher? No. So if the blood pressure goes up, these pressure receptors are going to be stimulated. They send a signal to the medulla. What's the medulla going to do? Stimulate what? Inhibitory centers. Inhibitory centers work with what? Sympathetic or parasympathetic? Parasympathetic. And the result is slow down the heart. What happens when you slow down the heart? Cardiac output decrease. So what? So blood pressure drops. Isn't that what you want? This is protection. This is negative feedback. My blood pressure goes up. That is bad. But I can correct it with this feedback. Okay? How about if my blood pressure goes down? These receptors are not going to send signal to the medulla. The medulla will say, okay, obviously the blood pressure is dropping. Now I need to activate which one? The acceleratory now. And acceleratory will activate which system? Sympathetic. And heart rate increase, and cardiac output increase, and blood pressure increase. You ended up correcting the blood pressure. This is how it works. Okay? It's also important to remember that the sympathetic, this is 233, but it's related, so you need to remember it. Sympathetic is using which hormone? Adrenaline or acetylcholine? Sympathetic, adrenaline. And parasympathetic, acetylcholine. You have to remember this. So there is also something called autonomic tone. Tone is the balance that is already there, like normal circumstances. There is a tone. It doesn't go like the pressure doesn't go to zero and doesn't go all the way up. There is a balance. There is a normal tone that's maintained by those two. It keep a tone there that's called autonomic tone, and this is due to the dual innervation and the balance between sympathetic and parasympathetic, or the balance between adrenaline, noradrenaline, both together. What's the other name for adrenaline? Epinephrine. And noradrenaline? Norepinephrine. So there is a balance between those four from one side, which is sympathetic, and the parasympathetic, which is acetylcholine. Um, so here is how we control the heart. This is called the cardiac plexus. What's the cardiac plexus? What does it represent? It's an example of what? Cardiac plexus. It's one of the dual innervation. It's one of the dual innervation to the heart. So cardiac output, which equal stroke volume multiplied by heart rate, change by there are different variables. And we talked about this before. You can change the heart rate and you can change the cardiac output, right? We talked about this. So if there is a parasympathetic that's taking the upper hand, it means more acetylcholine, and it means the heart slow down, right? What happened to the cardiac output? Decrease. And the opposite is for the sympathetic using norepinephrine. There is a reflex that I want you to know, which is called Bembridge reflex. It's one of the reflexes that help us to control the blood pressure and to maintain it. This is called Bembridge reflex or atrial reflex. Atrial reflex because it's a reflex that's happened in the atria. And Bembridge, obviously, a name, they give it away. Maybe it's for the scientist or something, but it's basically it adjusts the relationship between venous return and heart rate. What do you mean? Here is what I mean. Blood collecting in the right atrium. Do you remember that? You just have the exam. Blood collecting in the right atrium from the three different sources, right? And then go to the right ventricle, lung, left atrium, left ventricle, and then goes out, right? More venous return, more blood goes out. Make sense? 100 milliliters, 100 milliliters out. 150, 150 out. So the cardiac output will be more, isn't it? And this means the blood pressure is getting higher or lower with more cardiac output. Higher. So here is the reflex. The reflex is going to adjust this issue. When more blood come to the atrium, right atrium, there is a reflex to slow down the heart. Because the result is, if you don't do that, blood pressure will go up, right? What do you mean by increasing venous return? There are many factors. I don't want to go into the details, but there are many factors. Maybe you are overhydrated, you're drinking a lot of water, so your blood volume is higher and bringing more blood to the right atrium. Maybe you're exercising and you're squeezing your veins, pushing the blood up, whatever the reason is. But the bottom line is more blood coming to the right atrium, it has to be met with a reflex to slow down the heart, to avoid increasing blood pressure. Does that make sense? Bembridge reflex, you have to remember it. Hormones, epinephrine, norepinephrine, we talked about it before, plus thyroid hormone. Do you remember the thyroid hormone in the endocrine system? Thyroid hormone increase all metabolism, increase everything. It work like sympathetic, if you still remember. So sympathetic and thyroid. This is what increase the heart rate. So what else beside the heart rate can control or adjust the blood pressure? Well, cardiac output increase, blood pressure increase. Okay, more cardiac output. What does it mean? Either increase heart rate or increase stroke volume. Isn't it heart rate by stroke volume? So if one of those increase, the cardiac output will increase. Make sense? So if the heart rate increase, cardiac output increase. This is one. We talked about it, including the control. The second one is, what if the stroke volume increase? How stroke volume increase? I talked about that Tuesday. If I receive 100 milliliters and I pump out 60, so the stroke volume is 60. Instead I get relax more and get 120 and push it out, and I have 40 now, so it's 80 instead of 60? How about this? 120, and when it goes to 40, I even contract more. I end up having only 20. So now I pushed out 100. So can a stroke volume be 60? Can I increase it to 80? Can I increase it to 100? Yes. How? Increasing end diastolic and decreasing in systolic. Dilate more to gain more blood and contract more to push more blood out. This is how we control the second variable, which is the stroke volume. Now, how can I get more bloods in the end diastolic? More venous return can increase that. When the blood goes more blood will go to the ventricle, so it's going to dilate more and accommodate more blood. Venous return is one of them. If you give it the time, we call it the filling time, it is going to increase. Or if you contract more. The blood that's accumulating, that's coming to the heart, and this is the blood that's going to stretch the ventricles before you contract. This amount of blood that's coming in, we call it preload. Loading means when you contract and push the blood out. Preload before that. This is called the preload. Are we following? Preload. So preload is coming to you, and then you contract, push it out. Push it out against what? There is blood moving already, right? You're pushing more blood to the blood that's moving already. This is called the afterload. So what the blood coming to the heart before it contract, preload. And when you contract, you push the blood out against what? Afterload. So normally, what happened? Normally, if you're resting right now, what's happening to you? End diastolic volume, you relax, not too much, and you contract, not too much. This is normal in diastolic and systolic. But if you exercise, you're going to get more venous return, more stretching, so that will give you more end diastolic. And if you're exercising or something, you're going to contract even more, less end systolic. This is the effect of exercise. Okay? There is one more relationship that I also want you to know. When you gain more blood, end diastolic increase, right? Instead of 100, 120 now. Is that okay? More end diastolic. And when I contract even more. I can do that. If you're exercising, your heart work more. So you push more blood out. But there is a relationship here that you need to remember, which is the more you stretch to a limit, the stronger the contraction. They found this relationship. And to understand it, I usually do it like this. If you get a rubber band and you stretch it like this and leave it, it's not going to hurt you. But if you stretch it more, it will hurt, right? Because the longer, the stronger. The longer the beginning of the stretch, the stronger the action. So when you contract the muscles more to a limit, there is a limit. You can't it's not limitless. There is a limit that the more you stretch, the more power you get. And we call that Frank Sterling principle. Frank Sterling principle, which is explaining the relationship between length of the muscle when you stretch more, or there is obviously end diastolic volume more, stretching the muscle more, giving you more power to contract. Frank Sterling principle, you need to know this principle, plus the Bembridge reflex that I talked about already. So I talked about the preload, blood coming in before you contract. Afterload, the blood that's facing you, in front of you, after load. And contractility itself. Not all of us have the same power of our muscles, right? We can contract Some of us, contraction is stronger and others are weaker. This is one. Depending on the level of exercise, you can contract more or less. So this is one of the factors which is called contractility. So all these factors are controlling the cardiac output, including sympathetic, parasympathetic, anything of what I mentioned that leads to increased cardiac output, this is sympathetic. Anything that decreases the cardiac output is parasympathetic. Um, for the contractility, there are some um, pharmaceutical drugs that affect the contractility. It can decrease it or increase it. And this is more of medical stuff, so I don't want to go much into it. But this is kind of treatment of hypertension. Like if somebody's having hypertension, think about it. Maybe it's because the cardiac output increasing, obviously, right? Cardiac output increase, blood pressure increase. It's very obvious. So what should I do if somebody's having hypertension? What should I do? Decrease the cardiac output. How can I decrease the cardiac output? Decrease the factor that I told you about, including contractility. The more you contract, the more cardiac output. Clear? How about if I make the heart contract a little bit less? Isn't that going to make less cardiac output and lowering the blood pressure? Yes, this is a treatment. Like the beta blocker, beta receptors, are these sympathetic or parasympathetic, if you still remember? Beta receptors, alpha and beta. What is it? Sympathetic or parasympathetic? Sympathetic, parasympathetic. Think about it. Sympathetic. It's sympathetic. Beta is alpha and beta are sympathetic. Okay. Um, the others is nicotinic and muscarinic, if you still remember. But anyways, so beta blocker are sympathetic. So if I give you something to block it, your blood pressure goes down. Calcium channel blocker. Do you remember that calcium is a must-have for contraction? You have to have calcium. What if I give you calcium blocker? Less contraction, high blood pressure goes down. So these are not the only treatments. There are a lot of treatments for hypertension. But if we're talking about contractility, I want you to know that if you give a medication to make less contractility or weaker contraction, that drop the blood pressure. So here are all the factors combined. You can read it. But I told you what we need to know. Cardiac reserve. This is a term that I also want you to understand. If you are completely resting, you're not using your power much, right? I don't need to contract much. I don't need to increase my heart rate, right? If you're relaxing and not doing anything, do you need to do anything to increase cardiac output? To increase it for what? You're not doing anything, right? So this is the minimum that you have. This is the normal, the resting. Okay. Can I go more than that? Yes. If you're walking, get more. How about exercise? Yes. How about a lot of exercise, strenuous exercise? Yes, to a maximum. The difference between resting and the maximum is called the reserve. So you can utilize your reserve as needed. Okay. If I'm relaxing, this is resting. The best that I can do, the maximum with strenuous exercise, this is the maximum. Okay. The difference between those is a reserve that you can use as needed. Okay. If any one of you guys is going, like if you go to the gym and if you like talk to somebody there, they will tell you when you put your hand on elliptical or a treadmill or something, they usually tell you do not exceed, your heart rate should not exceed like 160 or something. Did we hear something like that? It's not like you're moving without limits. There is a limit, right? If you don't know that, you should know that. There is a maximum. It depends on the age and the muscle build and everything, but there is a maximum. There is a limit. And this limit is you're using your cardiac reserve. Okay? Can I use the treadmill like slow? Yes. Fast. When it go to a certain limit, this is your maximum. You utilized all your reserve. You cannot go more than that. And that's why in all gems, there is always this metal part. If you touch it, it will give you the heart rate. Do not exceed it. Don't think it's the more you go, the better it is. That's not true. There is a limit at which you use the maximum reserve. Okay? Okay, so that's it. Good enough for this chapter.